if a patient come to me, I will first introduce myself, ask the patient name to confirm his name, and then to his problem. What can be the problem? Either it can be the issue of the weight gain, the patients have increased BMI, the patients can have a fatigue, morning headache when he wake up, or a snoring either by himself or most likely by the partner. Or maybe he has complained of the sleeping while he was driving. Other things can be also irritability, impotence. This can be the other problem can be also there. So today our topic is obstructive sleep apnea. So these are the features with which the patients can come to you. So you have to think about that it could be also obstructive sleep apnea. So while we are going to talk about the obstructive sleep apnea, we will look on the basics and also ask in the last the patient concern also. So obstructive sleep apnea can also be called obstructive sleep hypoapnea as well, because the apnea literally means that there is no breathing, but in the real thing is the patient is having rather hypoapnea than apnea. So you have to also look at the patient's neck circumference also. It is more than 17.5 inches. That is also we have to look at. So here we can see there are two pictures. One is on the left side, another is on the right side. The left side the picture is the normal picture in which we can see that the air entry is normal. There is no obstruction. Even after the sleeping, the patient tongue is in such a position that there is no obstruction there. So the tongue, this is the soft palate, it is the hard palate, and while the patient is asleep, this tongues get relaxed and it's fall down. That is a normal things happen, but to certain extent, so that it should not block the air entry. Normally, hypoapnea happens up to less than 5, it's 4 times in 1 hour, that is normal. Here we can see that the air is entering well. Here we can see that the fall and obstruction is there and stop breathing. This gentleman is having the problem of air entry, so that is in hypoapnea. So less air is going inside, and that lead to the low level of the oxygen saturation. If we will connect this patient with the pulse oximetry, we will see that the oxygen saturation is coming down. This is a gentleman. It is real picture of apnea. We can see his mouth is open, is not breathing at all. There is no chest movement, and when the oxygen saturation go down, and it stimulate the brain, and that cause him to wake up. Here this gentleman, another video we can see that is a normal life, coming to sofa, watching TV, connected with the pulse oximeter. Good oxygen saturation, it is 97, and the heart rate is 68, we can see. While he is in the sofa, he fall asleep. Now we can see that it is written apnea, but I do not agree because there is some movement is there. So it is most likely hypoapnea. So because of the hypoapnea, the oxygen saturation is coming down, and it's coming to, now it is 68. So patient is breathing, but it is not breathing properly. It is a shallow breathing, and that lead to increase the um, decrease the oxygen saturation. Now it is a 58, and that is giving some stimulation to the brain, and this, see what happened next. So this gentleman now wake up because of the brain is get a stimulation, and oxygen saturation was markedly low, and that make him to wake up. So here is the history we have to find out the cause, that why this gentleman is having obstructive sleep apnea. Mostly also it is in the male. Female are the less commonly, and mostly postmenopausal ladies having this problem. So it is in the three forms. One is upper airway narrowing. So upper airway narrowing, we already saw that the obesity is the one of the reasons, such as in the hypothyroidism and itself obesity, many other reason also sedentary. Another thing then we have to look in the examination also, that what about the adenotonsillar hypertrophy. We have to look inside the throat, that maybe there is some hypertrophy is going on, and that is leading to obstruction. Macroglossia, big tongue, it can be associated with the hypothyroidism. So we have to look for the feature of the hypothyroidism, that is there any feature of the hypothyroidism is there or not. So in the history we have to ask. Next is the Down syndrome also. So we have to ask and examine also related to Down syndrome. Mandible can be small size and can be the big size. The small size is congenital, and the big sizes can be macro ganathia, acromegaly, the reason. Other is the upper airway collapse. It can be the rhinitis or septal deviation that lead to extra effort by the patient, and that lead to upper airway collapse. Third is upper airway muscle tone, that is decreased, and it happen normally, but it is happen quite markedly if the patient is taking alcohol or smoking. Also, it is related with the age. So mostly obstructive sleep apnea is more common, you can see, in the elderly people, and alcohol is the one thing. But unfortunately, the majority of the patient, we don't know the cause. We say that it's the unknown cause. So this is the diagnostic criteria for obstructive sleep apnea, in which there is A, B, C, D, three things. A is the clinical feature, B and C is the sleep test. In the A, we can see that the unintentional sleep episode during wakefulness, daytime sleepiness, unfresh sleep, fatigue, and insomnia. These clinical features in number one. Number two is the patient awake with the breath holding, gasping, and choking. And third is about the partner. The partner can also complain of breathing interruption and loud snoring also, or both, during patient sleep. Polysomnography, it is in the B and C, both it is there. The B is less severe form, which is the 5 episode of scorable respiratory event, and in the two, we have to look for the evidence of the respiratory effort that is present in the both B and the C also. So the second option is present in the both of condition, but the only difference in the one, it is 15 in the C, so it is more severe. Normal should be 4, and 5 is in the B category, and 15 is in the C category. And the last is the D. We have to rule out the other reason, okay? And if there is no other reason for the this episode. So, and if A, B, and D is there, then it is diagnostic. And if it is C and D, because C is the more severe form, it is with the D, means no other reason you got, then the C and D is even satisfy the criteria. And the severity you can see down, different types. What can be the complication? Cardiac arrhythmia, systemic hypertension, myocardial infarction, stroke, obesity, hypoventilation, other called the Pickwick syndrome also, pulmonary hypertension, and there can be also increased mortality. So there are many complications, so we have to look for what the treatment options we have. The easy one is, we can say that weight loss, stop smoking, stop alcohol. The main option is to intervene is the CPAP therapy, but we have to ask about the compliance, what the patient is facing at this moment, or the concern that patient have, maybe dry mouth, discomfort, noisy. LTO2E, oral appliance surgery, drug, that can be the other option also, in with the modafinils or the fluoxetine, SSRIs. There are some time helps, but the main treatment option is the CPAP, but we have to ask, and we can sort out the problem with the educating